Hello, I'm Hannah Donnert with the Collaborative on Health and the Environment. Change is bringing you the latest environmental health science through our partnerships, calls, webinars, science serves, publications, and social media. I would like to welcome everyone to today's final webinar in the series, Cancer and the Environment, Science and Opportunities for Prevention. The webinar today is titled Disparities and Cancer. Our moderator is Karen Wang, Director of CHE and founder of Because Health. We will leave time following the presentation for a brief Q&A session. You may type in questions to the Q&A feature available on the menu bar at the top of your window at any point during the presentation. After the presentation, our moderator will read out questions for our speaker to respond to. We will get to as many comments and questions as we can during the Q&A period. For those of you who called in on the phone, we posted slides to accompany today's webinar on our website. You can download these by going to healthandenvironment.org. Please scroll to the bottom of the page and select today's webinar. On the webinar page is a link to the slides. Everyone on the webinar right now is muted with the exception of our speakers. This webinar is scheduled to last for 70 minutes and is being recorded for our call and webinar archive. With that, I'll pass things over to you, Karen.
Great, thank you so much, Hannah. Welcome to our sixth and final webinar in our Cancer and the Environment series. We began with an overview of the issues and then dove into the recent scientific literature on occupational exposures, air and water pollution, heavy metals, endocrine disrupting chemicals, and pesticides. We heard about chemical mixtures in cancers and then childhood cancers. You can find videos of all of these webinars on our website. Today, to close the series, we will look at the disproportionate impact of environmental exposures on marginalized communities. This is such a timely topic, and we are excited to have three great speakers with us today. The first is Dr. Christine Ekenga. She is an assistant professor of public health and faculty co-director of Environment and Social Development Initiative at the Brown School at Washington University in St. Louis. Her research focuses on the environmental and occupational determinants of human health and well-being. Dr. Ekenga received her PhD in environmental health sciences from New York University. Our second speaker will be Anita Desikan. She is a research analyst for the Center for Science and Democracy at the Union of Concerned Scientists. In her role, she investigates the role of science and public policy, focusing on topics like scientific integrity at federal agencies and political interference in the scientific rulemaking process. She has an MPH in environmental health and science policy from George Washington University. Our third and final speaker is Caroline Eberle. She's a doctoral student in the Department of Epidemiology at the University of North Carolina Gillings School of Global Public Health. Prior to entering the program, she contributed to research on racial and ethnic disparities in employment and quality of life outcomes among working age cancer survivors. She received her MPH in epidemiology from the Columbia University Mailman School of Public Health. So we're really excited for all three of you guys. And Christine, I will hand it to you. Thank you.
Christine, do you want to unmute your microphone?
Thanks, Hannah and Kara, for the introduction. Thanks to CHE for an invitation. It's my pleasure to be with you today and present our study on cancer risk from air toxics in the St. Louis metropolitan area. So first, I wanted to provide some background on environmental justice and environmental and cancer concerns in the St. Louis area. And then I'll present the main results of our study and discuss implications of our work. So the environmental justice movement, it originated with the passage of the Civil Rights Act in 1964, but many consider events in Warren County in 1982 to be the catalyst for the movement. In 1982, the community, the Warren County community, a mostly African-American community, was concerned about the potential placement of a PCB landfill in their community. And despite these community protests, which included over 500 arrests, the landfill was placed in the county. Following these events in 1983, the Congress commissioned a report from the General Accounting Office And the purpose of the report was to look at the placement of hazardous waste landfill south. And what is that although African Americans only 26% of the population in the South, 3 out of every 4 hazardous waste landfills were located in African American communities. There were two key reports that were published in the 80s looking at the relationship between race, socioeconomic status, and the placement of hazardous waste sites. First is with the UCC, well, the first is with the General Accounting Office in 1983. The 1987 study from the UCC looked at toxic waste and race in the United States. What was interesting about this report is that they examined the statistical relationship between the location of a hazardous waste site and the racial and socioeconomic composition of communities. And they found that in all the factors they looked at, race was the most significant factor among the variables analyzed. So these are some of the key events and the key reports that made up the early events of the environmental justice movement. So what is environmental justice? Well, according to the EPA, environmental justice is the fair treatment and meaningful involvement of all people, regardless of race, color, national origin, or income, with respect to the implementation, the enforcement, and the development of environmental laws, regulations, and policies. By fair treatment, it means that there's no population that bears a disproportionate share of the negative environmental consequences resulting from industrial, government, and commercial operations or policies. Meaningful environment requires effective access to decision makers for all. So what that means is that there's an ability in all communities to make informed decisions and to take positive actions to produce environmental justice for themselves. So that's a little bit about the history of environmental justice. And now I wanted to talk a little bit more about the setting of our study. So our study is set in the St. Louis metropolitan area, the metropolitan statistical area in particular. And it's a 15 county region that spans Missouri, and there are about 2.8 million residents in this region. The largest city is the city of St. Louis. It's the center city in the region with about 300,000 residents. So most of the residents in this region live in the suburbs of the city of St. Louis. 75% of them live in Missouri. And in terms of racial the racial composition, 76% of the region is white, 18% is African American, and 3% are Hispanic. The education and poverty levels in our region are very similar to the national averages. We look at the geographic distribution of our population. Most of the non-white population in the region is clustered around the city of St. Louis, while for poverty, there are clusters of poverty throughout the region, in addition to in and around the city of St. Louis. So to discuss more about the origins of our study, there had been long-standing community concerns about cancer disparities in our region. And what a report from St. Louis County, the largest county in the region, they found that African-American residents had higher rates of both incidence and mortality of all-cause cancers compared to white residents. For 2 types of cancer, breast and prostate cancers, African-Americans were twice than white residents. There were also long-standing environmental concerns in the region, and we conducted a study, an in-depth interview study of environmental health concerns with African Americans in the region of varying socioeconomic backgrounds. What we found is that main environmental concerns have to do with air and water quality, flooding, crime, and safety. But what really stood out to us, and these were semi-structured interviews, there were no questions about race, racism, or discrimination in any of these interviews, but about 3/4 of our participants commented on race and perceived environmental injustices in their neighborhood. So to account those concerns, when we decided to examine air toxics in the region and organic air toxics in particular, and we turned to the EPA's National Air Toxic Assessment of 2011. It characterizes air toxics across the nation. And air toxics in this assessment, these are 187 pollutants that are known or suspected to cause cancer or other serious health or environmental effects. For cancer risk, we're looking at 140 toxics with benchmarks at the census tract level. And the air toxic assessment reports cancer risk estimates for each census tract. And their estimates assume that a person is breathing continuous exposure to these emissions over a lifetime, which is 70 years. So the air toxic assessment, according to the EPA, it's a tool to inform efforts to identify and prioritize air toxics, source types, and locations of potential concern with regard to air toxics. So the aim of our study was to examine the relationship between neighborhood characteristics and exposure to air toxics in the St. Louis metropolitan area. And our area was made up of 615 census tracts. So we linked the air toxic assessment data with census level data. We looked at race, ethnicity variables, income variables, employment, education, housing characteristics, over that we've looked at. And most commonly we use density measures, which are measures of, for example, percentage of African Americans in a particular census tract. Also, given the long-standing community cancer and environmental concerns about racial disparities, we also wanted to look at segregation. So we looked at two measures of segregation. The first was Black isolation, and the second was poverty isolation. So in the US, residential segregation, it's thought to influence health outcomes because of the way that it kind of sorts individuals into different economic, social, and physical environments. And when you're evaluating segregation, you need to be able to quantify how two or more different population groups are distributed across a space. So, you could look at the densities of the measures I mentioned before, but looking at ethnic density or the percentage of a population belonging to a group, it's not the most appropriate measure of segregation because it's not really able to describe how people or populations are spread out across different neighborhoods or census tracts in a region. So we believe that local spatial segregation measures are ideal, especially when you're going to look at the census tract within a metropolitan region like we have with the St. Louis MSA. So there are several measures and several dimensions of residential segregation. And in this analysis, we were using isolation measures. And isolation measures, they can be interpreted as the probability of a particular population group member meeting another member of the same group within the same neighborhood, or in the case of this study, a census tract. So the more detailed description of the formula for spatial isolation used that's in the paper published in Environmental Research last year. But just to quickly summarize, we came up with isolation scores that range from 0 to 1, 1 meaning segregation, to 1, the higher the probability is that you're interacting with another person or others who are members of your same group, and therefore means that you're in a more segregated neighborhood. Again, in this study, we were looking at two measures. One was Black-white isolation. So the isolation of the Black population from the white population, and then also poverty isolation. So isolating poverty groups from non-poverty groups. We used GIS to map the air toxics data to identify areas with statistically higher or lower concentrations of air toxics in the region. And we found that areas with higher levels of air toxics, they were located near the regional center, the city of St. Louis. And on the right-hand side here, if you're familiar with the St. Louis region, at the dark red clusters, they track along the major interstate highways in our region. And some of the big clusters are where the interstate highways intersect. Okay, so we looked at the relationship between neighborhood characteristics and exposure to air toxics in a region. And for all of our neighborhood density measures, we saw significant associations between these measures and exposures to high levels of air toxics. The only measure we did not see an association for was our Hispanic density measure. We also saw significant associations with both our isolation measures after adjusting for all the other socio-demographic measures. In fact, the Black isolation measure had a stronger effect compared to the effect of the other measures we looked at in this analysis. So what are some of the pathways between racial segregation and health? Well, we often find that polluting industries are more often located in disenfranchised communities. And these are communities where disproportionate numbers of people of color reside. So the people in these communities, they have fewer resources, they have limited social capital, and limited power to affect the decision-making processes that determine when industries are placed. So the entry of these industries into these communities, they can create what is like, it's called a cycle of vulnerability, and that it decreases property value, which negatively affects infrastructure and social capital, which then tends to attract more disenfranchised communities. So you have this cycle. Another pathway could be differential enforcement of environmental regulations, such as racialized zoning properties, property laws, or practices that disadvantage majority and minority neighborhoods, and also politically underrepresented communities. So what this means is that you have this differential enforcement, you may have racial discrimination in the housing market, and it limits the residential mobility of people of color, and it keeps them more concentrated in these polluted neighborhoods, which then leads to disenfranchisement, which then leads to decreased property values, which then attracts communities that are more likely to be disenfranchised. So again, this cycle of vulnerability. So to summarize our study findings, we found that there were significant associations between neighborhood, racial, and socioeconomic characteristics and exposure to carcinogenic air toxics in the St. Louis metro area. And these findings are consistent with prior studies, particularly the density measures we looked at, and also prior studies that have looked at isolation. So there have been a couple of studies that have looked at isolation and seen associations between Black isolation and exposure to these air toxics. I must say that the associations that we saw in this study, the relative risks were than had been reported in other studies. And we also found in this study that the main source of direct emissions in the St. Louis area are on-road mobile sources. There are limitations to our study, our analyses, they were cross-sectional in nature. And also, we're looking at census tract level data, so not able to account for individual level. Cancer risks, they were only modeled for a limited number, 140 toxics. So that is a limitation. And then finally, the assumption of 70 years of continuous exposure in the same census tract, that is also a limitation. But in terms of implications of our finding, implications for policy and future research, we have identified some locations of potential concern for future local air quality studies. And any effort in the region that involves reducing pollution, it should probably be accompanied by an effort to reduce segregation. So this would include policies that strengthen fair housing laws and housing affordability. Also, there should be some considerations of policies that promote public transportation. And finally, we're dealing here with a region of 15 counties. So any effort, it needs to be a region-wide effort. You have different municipalities creating different policies, which could have unintended consequences. So our plan is to extend this work by looking at other types of pollution, such as water quality, soil contamination, and also continue our community engagement. Now, recall community concerns, they informed our study question, and now we are out and we're going beyond our initial community collaborators to present our results to groups and other community forums. And these results will also inform our future studies in that we're working for a follow-up study looking at household levels of exposure to these air toxics. So I wanted to thank my collaborators and my funding from NCI and CDC. And again, thank the CHE for having me. And if you have any questions, feel free to email me or tweet at me. Thank you.
Great. Thank you so much, Dr. Ekenga. Great presentation and a lot of information there that's very useful for our audience. I'd like to give Anita a chance to pull up her slides and remind everyone to post their questions in our Q&A feature on Zoom. And we'll get to them at the end of the webinar after our final speaker, Caroline Eberle. So we've got 2 speakers left and then we'll get to the Q&A. So feel free to put your questions in. And it looks like Anita's got her slides up and we will be just ready to start here.
Sorry, just getting to the right slide here. Thank you again, everyone. My name is Anita Desikan. My analysis will be looking at a particular type of chemical called PFAS, contamination throughout the US, and we wanted to do an equity type of angle on this widespread chemical. So to give an overview, PFAS is a family of chemicals. It comprises approximately 5,000 different chemicals. It's very, very widely used in a lot of consumer products and industrial products since the 1940s. Some very famous examples are like Teflon and Scotchgard and firefighting foam. It's actually one of the reasons why military bases tend to be contaminated with PFAS. And just kind of the biggest takeaways about this chemical is that it does not break down very easily. It doesn't break down easily in the environment and doesn't break down very easily in the body. A lot of the health effects associated with PFAS are due to bioaccumulation in the body, actually. So there's a lot of different ways that this chemical, which unfortunately all of us here have been exposed to, can get into the body. But one of the major environmental contamination sources is drinking water. This is just a graphic showing the various ways that PFAS can enter our groundwater and our surface water, the sources of our drinking water. So this is kind of what a focus of our analysis is on. Now, to talk about the effects, the health effects of PFAS, they're multifaceted. There's so many studies. It feels like every day there's a new study showing a different type of health effect of PFAS that's been lately implicated actually even in COVID-related concerns. So this is a couple of examples from the CDC, and I'll point out the cancer risks. There's an increased risk of kidney and testicular cancer in particular. This is very well documented even by the WHO's cancer wing as a possible carcinogen. And I will give probably the most famous example of a study describing PFAS and cancer-related risks. It's maybe one of the largest epidemiological studies ever known, 70,000 people in the Ohio River Valley area, and the study is conducted from 2005 to 2013. The people in this region were exposed via their drinking water to a type of PFAS chemical called PFOA. There's a DuPont chemical facility in that area making Teflon pots and pans, more or less. The remarkable aspect was how they were able to link this chemical to 6 different types of cancers. And if you're interested in how this incredible study came to be, I'd recommend a movie actually from 2019 called Dark Waters that dramatized this study. So when we talk about PFAS, and I mentioned that it's widespread, mainly here, widespread across the world, although I'm going to be focusing this lecture on the US. I also want to mention that it's widespread in a way that can cause harm. So this is an analysis that my group did in 2018 where we looked at testing of military sites. We wanted to see what the groundwater contamination is nearby these sites and and how it relates to a minimal safety value established by the CDC. What we found was that overwhelmingly these sites are contaminated with PFAS above a level that the CDC considers unsafe, more or less. We only found one site out of 131 that didn't go above this level, and a lot of times it was going above 100-fold, 1,000-fold, even 10,000-fold. So. Now the main bulk of this analysis was, okay, this is a widespread chemical, but when you're but is this an environmental justice issue? Does this disproportionately affect indigenous communities, communities of color, and low-income communities? It's a scientific gap in the PFAS literature, and we wanted to try to address that gap. So this analysis came from a report that was published last year by the Union of Concerned Scientists called Abandoned Science, Broken Promises. We were looking at several aspects of science and policy making as it relates to marginalized communities, and how the current administration is actually exacerbating these harms. So the concept of environmental justice, which Christine beautifully gave a history of, relates to some of the nature of our own report here. The clustering of industrial facilities near communities is disproportionately leading to higher pollution loads and adverse health effects. And we wanted to see if PFAS would be an example of a chemical that is causing these disproportionate loads. So the way we did our analysis was we used a GIS mapping tool to look at different types of sites contaminated with PFAS. We found sites that have been contaminated by PFAS through publicly available materials, so government websites and news articles. I'll talk a little bit more about that data caveat later in the presentation. But just to note that whenever we basically found the site, we looked at the community demographics within a 5-mile radius around each site. And you can see from the visual representation here, we were trying to make sure we didn't double count people, and we were overlaying it with certain census data, census block data actually, which is the smallest measure available from the US Census. We partnered with Northeastern University. They're the ones who are holding this main part of the data set. And this is their map actually showing it. I just showed the civilian sites actually. The one thing to note about our nationwide testing is that it's obviously missing key testing data. The clumping that you're seeing of certain sites is not indicative, or not necessarily indicative, of major PFAS contamination specific to that site, but more an indication of increased testing. So like Michigan, for instance, has a very good statewide testing policy. All right, let's go to the meat of the analysis here. So our hypothesis is that PFAS is disproportionately located in low-income communities and communities of color, but I thought it might be important to talk about the null hypothesis that would indicate that this isn't going on. So if the null hypothesis is true, that means that the communities that are next door to these very contaminated sites are going to more or less equal what the national makeup of the US is. So that was the assumption of our particular study. And if we look here at the percentage breakdowns, the US census data indicates that low-income households is approximately about 5% of the population total, and ours is showing a slightly higher percentage that are located near these PFAS sites. It's a change of about 17%. And you can see something similar with people of color, about 22% higher. So we wanted to break these numbers down into kind of more real, how many people are actually being affected. So as you can see from this graph, we found about 4.8 million people are living in sites that are at major risk of PFAS exposure. And so basically we times it by these percentage breakdowns that I have here in blue. This is what the graphs look like. This is for low-income households, and the expected data is based on US Census data, and the observed is obviously the observed. So there's about 40,000 more low-income households than you would expect living nearby these contaminated sites. For people of color, the disparity seems to be greater. It's almost 300,000 more people. And this kind of sums up what I was saying, but it appears that there's a type of environmental justice issue occurring in these communities. More or less, it indicates that low-income communities and communities of color are more likely to be located near PFAS contaminating sites. Therefore, when we set appropriate standards and enforce these standards, there's likely going to be an equity component. It's going to be especially important for underserved communities. And I'd like to discuss a little bit about how PFAS has been regulated and tracked by the US government in my next slides. So unfortunately, it's marred by a lot of inaction and missteps. One of the most important was from 2018. Do you remember when I spoke earlier about a certain CDC minimal risk level? This came from a report from 2018 that was actually buried by the Trump administration. They were buried it and because it could be a potential public relations nightmare. The only reason why we even know about this particular study is due to a Freedom of Information Act request and a public outcry to get the draft published. Even now, the final version of this report has not been published. The Environmental Protection Agency has not been systematically tracking or regulating PFAS. There have been some recent developments that I'll go into, but this has been traditionally the case for this agency. They have a health standard right now, but it does not match what the CDC says is a health risk. It's about 7 to 10 times too high. The action plan set up by the EPA is also just doesn't carry teeth, more or less. It's not enforceable and it's not strict enough. It does not follow the science, the best available science. Furthermore, PFAS is not considered hazardous by the EPA, despite, again, the overwhelming scientific evidence that it can be hazardous to health. Therefore, Superfund sites, which are usually located in near communities of color, are not being prioritized for cleanup. There may be some changes here with this. This is an article written by a colleague of mine from February. So the EPA appears to be providing some regulatory actions on PFAS, especially for an enforceable drinking water standard, at least for the 2 most well-studied versions of PFAS. This is a good step. This is a good step that should have happened a lot sooner, but it is still uncertain how it's going to shake out. Another positive is congressional action. So the National Defense Authorization Act is a congressional act that monitors, that deals a lot with military-related concerns, including military bases. And like I mentioned, PFAS has contaminated a lot of military bases, so this has become a priority in the last few versions of this act. And one of the most important is this one that was just implemented just in June. As I mentioned, a major data caveat of our study is that it wasn't systematic. It didn't cover every single site that had PFAS contamination because that data is quite literally not available. However, this might change because of this congressional action. The EPA will now be asked to put a number of PFAS chemicals under the toxics release inventory, which is one of their major ways of tracking chemicals. So hopefully we can get better data in the future. Other developments, states have been leading the charge, at least a few states, with enforceable drinking water standards, monitoring, and cleanup. Like I mentioned in my previous map, Michigan has been a major player in this, New Jersey and a few other states as well. So a lot of the PFAS data that we have are coming from sites that are actually tracking them. And like I mentioned, the Congressional Act is putting in some needed measures to track and regulate. And right now, the current version of this is being debated in Congress as we speak, and it's expected to include even more measures. Finally, I'd also like to note there's a major CDC study going on right now that could show certain types of health disparities with PFAS. It's a multi-study site, about 6 different sites across the US, looking at 2,000 children, 6,000 adults for potential health disparities. So there are efforts going on right now to try to understand this problem a little bit more. And that is my presentation. Thank you.
Thank you so much, Anita. And I want to remind you guys again to please put in your questions in the Q&A feature on Zoom while Caroline is uploading her slides. And we will move shortly to her presentation. with you in just a moment, Christine. It looks
All
good.
right. Are you able to see the slides now?
Yes, it's great.
Okay, great. Well, thank you, Hannah, for the introduction, and thank you to Shay for this opportunity to present the findings from work I did with investigators at the National Institute of Environmental Health Sciences, titled Hair Dye and Chemical Straightener Use and Breast Cancer Risk in a Large U.S. Population of Black and White Women. Some background: breast cancer, it remains the most commonly diagnosed cancer among women in the United States, with an estimated 270,000 new cases in 2019. Unlike many other common cancers, including lung, prostate, and colorectal, which have seen declines in annual incidence in recent decades, breast cancer incidence has remained relatively stable. And as the figure on the left shows, from the American Cancer Society's 2019 Breast Cancer Facts and Figures publication, breast cancer incidence has increased slightly among Black women in recent years, converging with the per capita incidence observed in white women in the US. And though total breast cancer risk is similar, the figure on the right illustrates that Black women remain at a higher risk, or at the highest risk, for hormone receptor negative breast cancers, which are more frequently diagnosed at a younger age, have poorer prognosis, and fewer known modifiable risk factors than hormone receptor positive cancers. Hair dye has been studied as a potential risk factor for breast cancer since the 1970s. A recent NCI report estimates that a third of adult women in the US regularly use hair dye. Dyes are classified based on how the constituents bind to the hair. Permanent dyes, or oxidative dyes, contain colorist precursors that react with oxidizing and alkalizing agents to bind to the inner cortex of the hair, as to semi-permanent and temporary dyes, in which colored particles bind to the outer layer of the hair in the presence of very little, if any, concentrations of oxidizing and alkalizing agents. Of note, endocrine disrupting activity has been observed in many of the aromatic amines commonly used as oxidizing agents in permanent dyes. Some of these compounds have been found to induce mammary gland tumors in animal models, and DNA adducts for 4-aminobiphenyl, an aromatic amine that is regulated in some markets, were 8 times as likely to be identified in breast tissue of women that regularly use permanent hair dye. Toxicological assessments of products in the US have determined that many of the UDCs and estrogens found in hair dyes are not indicated on product labels, and that darker colored dyes and products marketed to Black women have higher concentrations of these constituents. Chemical straightener use is less common in the US overall. However, this varies greatly by race, with 60 recent studies reporting 60 to 80% of adult Black women having used chemical straighteners. Common formulations include non and non-lye relaxers, which have raised health concerns due to frequent scalp burns, and semi-permanent keratin treatments, which, though they cause fewer burns and hair breakage, the process involves heating all volatile organic compounds, including formaldehyde, in the straightening process. Our research had 2 main aims: to describe the association of breast cancer, or of permanent hair dye use and breast cancer risk, and how this association varies based on frequency of risk, type or color of dye, and estrogen or menopausal status of women at diagnosis. And the second aim, we described chemical straightener use and breast cancer risk with consideration for frequency of use, estrogen receptor, and menopausal status. We conducted the study using the NIEHS sister study, a cohort of over 50,000 women in the US enrolled between 2003 and 2009. All participants have a sister who's been diagnosed with breast cancer, but no personal history of breast cancer. Participants completed extensive baseline questionnaires and have completed annual health updates and biannual surveys in the time since. Participants are able to report breast cancer diagnosis during the annual health updates or by calling the Sisters Study hotline, and pathology reports, including the presence of the estrogen hormone receptor, are available for around 80% of cases. Our study sample included the 46,709 women with complete baseline information on exposure and covariates. The study was based on information collected through September of 2016, at which point there were 2,794 confirmed breast cancer cases and an average of 8.3 years of follow-up. Our exposures were measured at baseline, and they include personal use of hair dyes and chemical straighteners broken down by use in the past 12 months, frequency of use, duration of use, and then type and color of dye. We also assess non-professional application of dyes and straighteners to others. The primary outcome in the study was invasive breast cancer or ductal carcinoma. In secondary analysis, we considered breast cancer broken down by estrogen receptor status and menopausal status at time of diagnosis. Risk was estimated using Cox proportional hazard models with age as the time scale, and we tested for heterogeneity between Black and white women. 55% of the study sample reported having used permanent hair dye in the past 12 months. Users were younger on average, and Black women were the only racial group for which a majority of participants had not reported permanent dye use in the past 12 months. 10% of the sample had used chemical straighteners, but this was 74% of Black women, and a larger proportion of premenopausal women reported use of both products. Permanent hair dye use in the past 12 months was associated with a 9% higher risk of any breast cancer, and there was a small but significant association with frequency of use. Use of light-colored dyes was associated with a 12% higher risk of all breast cancer. The risk associated with frequency of use in Black women was more pronounced. Breast cancer risk was 60%. Breast cancer risk was 60% higher among frequent users than non-users. And use of light-colored dyes was associated with a 12% higher risk in white women and dark-colored dyes a 51% higher risk in Black women. Risk did not differ between pre- and postmenopausal breast cancer for most exposures, with exception of light-colored dye use, which was associated with a 30% higher risk of premenopausal breast cancer. Chemical straightener use in the past 12 months was associated with an 18% higher risk of all breast cancer, and frequent use was associated with a 31% higher risk. Women who had applied straighteners to others also experienced a 27% higher risk. None of these associations varied significantly between Black and white women. Any chemical straightener use, frequency of use, and application to others were all associated with breast cancer in postmenopausal women. So as we anticipated, permanent hair dye use was associated with breast cancer, particularly among frequent users, Black women, and women using dark-colored dyes. We did not see associations when the outcome was stratified by estrogen receptor status, and personal use of any semi-permanent and temporary dyes were not associated with breast cancer risk. We did see that application of semi-permanent dyes was associated with estrogen receptor and postmenopausal disease. Chemical straightener use and frequency of use were associated with risk, and this did not vary between Black and white women. Though we didn't see significant effects, there was suggestion that the association was driven by stronger associations with estrogen receptor negative cancer. Our findings are similar to two recent case control studies conducted in the New York City area and in Ghana. And this is of interest given the common timing of our exposure windows between the three studies. Though we didn't have the information on the type of straightener used, Brazilian keratin treatments that were popular during the early 2000s became subject of scrutiny around 2010 in response to complaints of sensitization from salon workers. An investigation conducted by Oregon's Occupational Safety and Health Association in 2010 found high concentrations of formaldehyde in keratin treatments at all 54 salons where they sampled. And this was sparked interest among both consumer advocate groups and major news sources. Formaldehyde is classified as a carcinogen based on risk for nasopharyngeal cancer, but has not regularly been studied in association to breast cancer. Overall strengths of our study include a large national sample, prospective data, and extensive exposure information. Our participants are great with over 90% follow-up retention at nearly every data point, and we had sufficient sample to estimate effects separately in Black and white women. The study was reported or limited by our use of self-reported data, and the product formulations were not known, often not known to consumers who use them. And our exposure windows were limited to the past 12 months. We weren't able to track use during follow-up. For future directions of this research, in the coming annual assessment, we will be asking participants about the types of chemical straighteners and relaxers they had reported using. And we are currently completing a study of early life exposure to hair products around the time of menarche and breast cancer risk among sister study participants. So I'd like to thank all of the sister study participants, my co-authors and mentors on this project, Lexi White, Kyla Taylor, and Dale Sandler, and our funding sources. Thank you.
Great, thank you so much. We'll be moving on to our Q&A portion of the webinar now. So please, if you haven't already, put in a question and we'll get to as many of those as possible. And just a minute, I'll be passing this off to Karen. She's going to be asking the first question.
Great, thank you so much. Dr. Ekenga, we have a question for you. What was the data source for your Black and poverty isolation metrics?
So we used census tract level census data for our isolation measures. And if we can pull the slides back up, you can see an example of our calculation for the Black isolation measure, where we're looking at the Black population in a particular census tract compared with the population in the entire study area. I will say that applying these isolation measures depends on the size of the geographical area that you want to study. So an MSA like the St. Louis metropolitan area is very appropriate for this application. But for a smaller area, you may want to consider other measures of segregation and even the density measures that I mentioned before.
Christine, do you want to send me to the slide? Which slide was it that you were?
Next slide. It is with the check boxes, the checker boxes. If you keep going. Going. And next slide. Yeah, the one before this, the maps. We go back.
While we're finding the slide, a follow-up question. What was the correlation between the poverty and Black isolation metric?
They're very correlated, which is why we looked at them separately. Several of the variables, when you think about, education, unemployment, and race in the St. Louis area are correlated. So we have to either, do some reduction or take that into account when we were doing our multivariable analyses. So on this slide here, you can see our formula for Black isolation, and it's using census data. So here we were linking 2010 census data with the 2011 National Air Toxic Assessment. And this is an example for Black isolation, but we've also created isolation measures for poverty and unemployment as well. And if you feel free to email me, I can share some more sources with you with more detail about these calculations.
Yeah, we had another, it was kind of a question comment for you that was about in California, there's been local low-cost air monitoring in our state. And many of these monitors are in Latinx communities. Is something like that happening in the St. Louis area? Are you looking
No,
at-
unfortunately, with the limitations with EPA monitoring, in the area in the metro area, we have about 25 monitors throughout. So that's a goal of our follow-up study, to do more local monitoring, particularly at the household level and the personal level, to get a better idea of the exposures that some of these residents experience.
Okay, great. Let's see. There was one more question for you. In your study, I believe you already answered this, but did the study include a focus on pediatric cancers? And so, if so, can you please advise what you found?
So our study did not focus on a particular cancer type. We were working with estimates of lifetime cancer risk. So the idea is, if you are in a particular area for 70 years with continuous chronic exposure to these pollutants. So you can imagine the limitations with that sort of analysis, but with some follow-up studies, we do plan on looking at the associations between certain types of pollutants and types of cancer outcomes.
Okay, great. Anita, we had a question for you. Do commercial water testing companies test for PFAS in private well waters? And I guess, did the data that you use look at private well waters, or can you talk a little bit about that?
Yeah, so unfortunately, I don't actually know the capabilities of commercial water testing for PFAS. So I'm unfortunately unable to determine if that is a capability. I will say, yeah, in the data sets that it was well water wasn't factored in. It was groundwater and surface water contamination. That was the main sources of those data sets.
Okay, and did your data look at military sites in the analysis?
We specifically looked only at civilian sites, non-military sites.
Was there a reason why you didn't include the military sites?
So there's not actually good systematic data to track the communities that live next door or on military sites. Some of that data is considered classified by the US government. So we wanted to just pull that out of our analysis so we're able to get a more proper demographic look.
Great. We had another question for you. Have you studied airborne exposures of PFAS disposing through incineration?
That's actually a great follow-up question. We haven't specifically studied that within our group, but that is indeed a major source of contamination. The incineration process that leads to airborne exposures. But unfortunately, I don't have further details on that, but indeed that is actually a major concern right now.
Great. Carolyn, we had some questions for you. I guess the first one, could you talk a little bit about just breast cancer? One of the questions was, are the causes of breast cancer more genetic than environmental?
So looking this up, breast cancer is largely associated with reproductive factors in women. Those have been most strongly associated, such as age at menarche, number of children, birth, and breastfeeding. These things have primarily been associated with estrogen receptor positive cancers, and their overall fewer risk factors have been associated with hormone receptor negative cancers. Previous presentations in this series, some other investigators, Lexi Lloyd and Nikki Nyhoff on the sister study, have presented work where they've seen associations with particulate matter and different air toxins. So there has been look at particularly different chemicals that have endocrine disrupting principles or activity, but toxins in association to breast cancer risk.
We had a question, what components of hair dye are disclosed or not disclosed on labels? And are there regulations to monitor and hold manufacturers accountable?
So currently, the regulations of disclosure and what can be contained in hair dyes in the US are not great. Last year, Representative Jan Schakowsky, who is the chairwoman of Consumer Protection and Commerce Subcommittee in the House Energy and Commerce Committee, introduced a bill on safe cosmetics and personal care products that would address a lot of this lack of regulation. And to my understanding at this point, it is sitting in the House. Further, we've also just kind of looking into the interest in the Brazilian keratin treatments. There has been a lot of information about risks associated with those posted on the FDA's website, but it all just describes risk associated with use and hasn't had much like regulatory or involvement and restrictions on the products.
Okay, great. What are the potential health implications of differentiation in disclosure of ingredients in salon hair dyes versus over-the-counter hair dyes?
I don't know that I can speak to that as much. I know some things we have read where they've done sampling at salons, they found that even beyond the products that the salons bought, that there have been contaminants mixed in, and so that's perhaps even a source of more ambiguity in what people are being exposed to. But the hair dyeing process is different between permanent dyes used in salons and semi-permanent dyes used at home, and which is why the concentrations of chemicals is different. But I'm not sure I can fully answer that question.
Okay, thanks. Dr. Ekenga, there was another question for you. What is the smallest geographic unit you have for cancer data available in St. Louis?
So I'm limited by what's available in the EPA air toxic assessment, and their smallest is the census tract.
Okay, great. Let's see, I think that is all the questions that we have, and we are almost at the top of the hour. Are there any other questions? Please type them into the Q&A quickly. And if not, then Hannah, I will hand it back over to you.
Great, thank you so much, Karen, and to all of our speakers today. We're approaching the end of today's webinar. A video recording will be available on SHEA's website soon, and tomorrow you'll receive an email containing a link to the video. The next SHEA Alaska Partnership Call will take place July 29th and is titled Lessons Learned from the Alaskan Home Garden, Consequences and Alternatives to Pesticide Use for Our Soils, Plants, and Ourselves. Then on July 30th, we will hold the first of two series webinars titled Agents of Change, Amplifying Voices of Future Leaders in Environmental Health and Justice. To learn more and to RSVP, please visit our website at healthandenvironment.org. If you are new to SHEA and would like to stay updated about upcoming events or more, please sign up to receive our newsletter by selecting the Join Us tab at the top of any page on our website at healthandenvironment.org. Additionally, if you appreciate these SHEA partnership webinars bringing you the latest environmental health research for free, we encourage you to support SHEA's ongoing work by making a tax-deductible donation via our secure website. Again, our website is healthandenvironment.org. With that, I would like to thank our speakers, Christine, Anita, and Caroline, for taking time to present today, and to you, Karen, for your excellent moderation. Thank you so much for joining us. Have a great day and stay well and healthy.